For the first question, what is the average age group of patients diagnosed with CML in your clinic these days? Dr. Ross, would you like to start?
In Australia, it's around 55.
So truly, it's an adult disease. But you have young patients, young adults.
So we don't see people under the age of 16. So we have adult hospitals and child hospitals. So people aren't allowed to come if they're under 16. I think my youngest patient was 18 or 19 when she was diagnosed. So we do see teenagers, but we don't see children in my practice. But I have colleagues in the Children's Hospital who do see children.
All right, Dr. Chang.
Patients that used to be pediatric cases, then when they are more than 16 years old, do you see them, or they are still being followed up by pediatric hematologists?
They do when they become 18 years old or around 18 or 20, they have to move to the adult hospital, and so then they'll come to one of us. But because it's so rare in children in Australia, I don't personally have any patients in that age group.
Okay. When we first started our registry, we used to think that CML occurs in a younger age group, so we started with 30 to 40 as a median age. And then subsequently, when the data collection gets bigger and bigger, it goes to 40 to 50, and now it's probably around 50. So I think it's one of the problems with countries, again, in this region is that, the registries are not as robust. I don't think the characteristics are that much different, but, as our registry got larger, I think I see the trend towards older patients. Many older patients don't come to the hospitals, don't get diagnosed, and I think it's just data collection.
I think the age generally is, over 16 is adult and below 16 is pediatrics. So I know that in India, we have a lot of little children, right? I think our youngest patient is like 1.5 years old. And we have quite a few. Hari, would you like to say something on that? Because I know the pediatric unit looks after a lot of the patients.
Yeah. Actually, our pediatric unit did present most of the, one of the largest series of patients on CML, which was about 60 odd patients. We see patients after the age of 15. So we have, I would not say that we had a huge population, but we have a significant proportion who are what we call as adolescent young adults between 15 and 25, which would probably constitute about anywhere between 5 to 10% of the CML population that we see. And given that our median age is probably somewhere between 40 and 50, somewhere around 45, I would think, as the median age of presentation to our clinics.
Same with us, Dr. Ross. Our patients, adolescent, is around 3 to 5% of the total CML population, Philippines.
In Japan, I think as a national level, the average age group is the age would be in the late 50s. In our institute specifically, because we do quite a lot of stem cell transplant, the referral that we receive is more in the younger generation. So specifically in my institute, it would be a little bit younger, probably around 50 or maybe late 40s. The practice in Japan is also that we only see, in the internal medicine field, we only see patients above the age of 16. So the youngest patient we have a diagnosis probably 17.
CMLers, just long-term. CMLers on a long-term treatment today, diagnosed at younger age in this region with more prescription options, better prognosis. So the question is, your observation as clinician while dealing with relatively young adult patients, can you share one challenge with us, please? Pramod, would you like to? Oh, no, this is for clinicians or Dr. Ross, sorry.
One very obvious challenge, of course, in younger women is pregnancy. And it's always difficult. One of my youngest patients was pregnant when her CML was diagnosed. And then it's a very difficult decision. Is it safe to continue with the pregnancy? So that woman had a healthy baby. And then a year later, she comes back and says, I want another baby. when her CML is hardly under control. So that's a huge challenge. I would try to encourage someone in that situation to spend a couple of years to get the CML under control, and then to have a planned pregnancy after the CML is well controlled. But for some people, the wish to have a baby is so strong that they sort of don't even care about their own health because it's so important to have a baby. So that's a huge problem. So I explain to women in that situation, well, you know, your child has to have a mother, and if you die, your child has no mother. It's very important to control your disease. So this is a huge challenge.
Dr. Chiang?
I was trying to dig out those adolescents that we had from our registry and, you know, try to present something here, but unfortunately, Mei Ching and I just didn't have the time. It's just my impression that most of our adolescents did not do well. They progressed. We had tough time talking to them, spending time with their parents. Many of them stay in hostels, youth hostels, you know. They go to school and no one is monitoring their intake. So I think compliance is a real problem. Having a child is very important. I think in an Asian culture, you know, your in-laws are not going to be very happy here if you do not have a child. So unfortunately, that is the reality. And I think for me as a physician, the easiest is really to tackle it head on. So meaning that if you have a young patient who turns out on your doorstep with a diagnosis of CML, I think you really have to approach the subject. What are your targets? You know, to start off, you know, with, you know, whether they're planning to get married, what are their plans, and so forth, so that, you know, they understand what are their targets, so that, you know, for us, we try to get them into at least an MMR first, but we routinely, after the MMR, we switch them to interferon and then to maintain them, and then we refer them to the ONG, and then we tell them, look, your target is to get pregnant within this year and make sure you get a baby, because we cannot promise you that we can hold on more than that, you know. So these are some of the things that we do. I think the most important thing is really to tackle them upfront. Meaning that, you know, the minute they get diagnosed, you know, what are their plans so that they know what to do, you know, and rather than sometimes when they come pregnant, and I think it's then very difficult.
We have an increasing number of patients who wish to become parents, more so among the male population. They come forth and say that they want to have a baby, and that becomes a lot easier for us in terms of recommending what to do. But I have two situations as far as ladies becoming pregnant. One is a situation which I used to deal with day in and day out about 3 to 4 years ago, when they will just come and announce that they are pregnant, and we'd say, how many weeks is it? They would say, oh, it's about 4 months, and then you have nothing to do about, because they have already been on the medication, and you don't know what to do, and it's way beyond even recommending them to consider MTP, but it doesn't work. And so we have had situations where they have continued on the medications and they have had healthy babies, but we really don't know what to do at that point of time. The second situation is, despite telling them that it is not advisable to become pregnant or do it a plan, they still go ahead and become pregnant. And again, since the follow-ups are every 3 months, again, you can't do anything about it. But more frequently, there are people who asked, young women who are starting out on treatment for pregnancy, for CML, and then you are in a position to counsel them as to what to expect and how to go about it. And recently, just about 2 weeks ago, I had a couple who were seeking the same advice, and I said, first, get your medications right, get into some sort of a response, sustain that response, and then we can look at it at that point of time, because it's more important for you to get the disease under control at this point of time.
So definitely pregnancy is a big issue in the young population, especially for women. Beyond that, I think it's also similar in some other Asian cultures. Two topics. One is adolescents who are going into university, and there's a huge peer pressure to go into a good school, and keeping up with the school studies with the side effects might be a big challenge for some of our young population. Another topic that I have been consulted with, going into marriage, and I think the stigma of having a disease in the Asian culture is one of a major issue, and sometimes disclosing that they have an ongoing disease and on current treatment, although their life expectancy is very good in CML's patient population, sometimes they do struggle how to disclose their situation to their partners or the family of their partners.
I'm wondering if any of the the physicians who are now seeing younger patients, and you're seeing younger patients for longer periods of time, do you see, are they different profile of patients? Do they ask you more questions? Do they come to you with, doctor, I saw this on Google, and so are you having to kind of assume a different persona when you treat a younger patient? I don't know if Pramod, as you've been on the drug for like 12 years now, so you were very young. You're now very old, of course, but you were very young when you went to your doctor first. So I don't know, if that would be interesting to know.
Okay. Today, there are a lot of people, even for meetings, when we meet, I personally tell them to do less of Google search, because what happens is they come out with all the negatives, and they pester the doctors when we have our meetings with all the negatives rather than the positives, because those are the things that come in first. Morning when we were discussing about the side effects, like even a common cold, they would say, attribute it towards, is it a part of this Gleevec that I'm taking, that I have this cold, I have this leg ache. As a common man, there would be a lot of side effects which, not only for medicines, it might be your daily lifestyle that you live in, that might be having these ailments that you have. But because someone is taking this medicine, it's always the first thing that comes to mind, oh, because I'm taking Gleevec, this might be a side effect of it. Whereas it might not have to do anything with it. So coming back to the point that you asked, Rama, a lot of people who do their own research and they come to their own conclusions, which is, I feel, a wrong trend or a dangerous trend, because that might be one reason why there are a lot of dropouts or people who are thinking of stopping the medicines. Okay, for 5 years, I've been constant on that. There's no negative impact. The medicine is giving a positive impact on my this. So should I be stopping this medicine? A thought that is coming into their mind.
Okay. For second to the last question, basically this is a physician question, but I'd like to throw back the question to you, Pramod, because what the doctors know is different from what we know as patient leaders. Compliance in young adults, how big an issue is this in your group?
Okay. Compliance is one thing that we in India have started to make the people aware of it. There are a lot of things which contribute towards of bad compliance. And what we have found out is the major reason is a sort of lethargic way of, okay, everything is going all right, so let me skip it.
Do you have cases or points in time wherein you would like to believe that these young adults are telling us they're not taking the medicine and they're scared to tell their doctors that, but they're not scared with us? They tell their peers, our other members, no, actually I missed doses, but I'm too scared to tell the doctors. Do you have cases like that?
Not that sort of. Wherein it's just casually they're missing it. Not seriously, or not in a case where they don't want to inform their doctors, nothing of that sort. It's just that they missed it and don't care about it. I'll add to what Dr. Hari said in the morning. It might be a reason why a major chunk of people not bothered because they're not paying it from their pocket. They might not be feeling the pinch of it. Okay, I had to strive hard for that medicine. When you have to work for something, the pains that you take for that might not be that high. That's why they might be casually saying, oh, I forgot it. That's it. But over the period of time, what we have analyzed is the compliance level has increased a lot with the awareness that we are spreading. So
Okay.
as patient advocates, when we have our meetings, we meet people, we should ensure that we talk about compliance so that that becomes important for them to realize the importance of compliance and the levels increased.
Okay, so let's get some expert views this time. How does compliance impact the disease and its management with regard to young adolescents? Dr. Ross?
I would agree with Dr. Chang. It's a major problem that this period of rebellion or wanting to be the same as your friends, and your friends don't have CML, so you don't want to have CML either, and taking the tablet is a constant reminder that you're different from other people and you have side effects that other people don't have to live with. So it's a major problem. And this is not just CML, this is every disease. A friend of mine is an endocrinologist and she looks after teenagers with diabetes. And she said as children, their parents control their lives and everything is beautiful. And then they become adolescents and they want to do their own thing. They don't want to be told by their parents or by their doctor, and things suddenly are a complete disaster. And then maybe when they're 30, things get better again. I think adolescence in Australia runs for a long time. I don't know about your countries, but I think people are adolescent now until maybe 35 or something. So it is a huge problem, and I don't know what the solution is, because I think this is a phase in people's lives when they don't want to be told what to do.
Dr. Chang?
Yeah, but to add on top of that, I think compliance is probably also a much more complicated issue. I think there are many other reasons for compliance. I think it is also a behavioral issue. Some people are just not compliant. You know, they are just born, their genetic makeup, you know, they're just non-compliant, and perhaps there's very little that we can do to overcome that. The other issue with compliance, I suspect, is also a little bit of intolerance, and that is where I think there is a major disconnect between what we consider as physicians has side effects, as what the patients consider as side effects. I know young patients don't like to gain weight. You know, so some of our imatinib patients really put on, you know, they become 100 over kilograms, you know, they just hate it, you know. But for us, it doesn't seem like a major issue. We say, go exercise, restrict your diet, but to them, it is a major issue. The other thing is, you know, this skin changes, you know. Some of our younger patients don't like this fair skin, you know, they don't like this appearance. But to us, it doesn't seem like a very bad side effect, but to them, it is also. I think the intolerance issue between what we see as a physician as serious, and you know, and some people don't like this nausea, this slight nausea, because it makes them sick throughout the day. They don't like to go on a holiday feeling, no, who wants to go on a holiday feeling like you are pregnant, right? You know, you don't want to feel like, you know, you want to feel good like any other, you know, so I think those are issues that we really have to address, you know, if we want to improve.
Okay, sometimes you would see me nodding my head because some of the things you're saying is hitting me on the spot. My kid had CML when he was 8 years old. He's now 16. So most of the problem, we have, as parents, we have problems dealing with normal adolescents, much more with CML adolescents. So let's go now to the next question. Coping with side effects. Is it a fact that only older patients are susceptible to side effects? Maybe we could go to Dr. Hari for this one.
Side effects, it's not just confined to anybody. Anybody can get side effects. It depends on how they handle the drug, and it's not unique for any particular person. But yes, sometimes we see more of cytopenias with older patients, and it can become quite a challenge. And it's important for us to identify whether there are any other cause for the cytopenias in these patients, and but in the same breath, I would say that's a problem sometimes in one of the younger patients when we deal with, more other metabolic disturbances that you come across. Because as such, the older patient may have some bit of organ compromise or something, and when you when you just tip the balance a little bit when you start them on some of these TKIs. But overall, imatinib is pretty well tolerated, and you come across these things with the second generation tyrosine kinase inhibitors. But otherwise, we have to take it one at a time. And yes, I would agree marginally in older patients, cytopenias may be a little bit of a problem.
Can we ask you the second question? Does, in your experience, being also an advocate, does the younger patients cope better?
I think it is very individualized. And in India, maybe the younger patient, because they are still under control of the parent for a longer period of time, so they tend to get through with it a little more easily, I think, because I have so many patients who are in the college age group who are taking the medications. It's more important to become their friend while talking to them and discussing them in a light vein, rather than give them the impression that I'm the doctor and I'm telling you that it has to be done this way. It helps a lot just to be very casual with them or joke with them about what might happen if you do not take your medications regularly. Yes, I wouldn't say that it's any different. Every age group has got their issues, but it's just how you handle them. Yeah, because everybody would agree, as you go by, they are more your friends than your patient.
Dr. Eri?
So basically, I agree everything that has been said. Personally, it may be just the Japanese culture, but a generation difference is a major issue in tolerating side effects. And personally, I feel that older patients are more better at managing their side effects because they've just gone through this whole life experience. They know what could happen, and sometimes they have better communication tools with the doctors as well. And sometimes it's more difficult for the younger patients actually to tolerate and cope with the side effects.
I just wanted to share something that happened exactly maybe 10 days ago when we had a patient support group in Bombay, and Dr. Hari was the physician who had come. So we have a young survivor. She must be around 32 years old now, and she had a bone marrow transplant when she was around 20. And Dr. Hari Menon was a resident at that time at the institution where she had her transplant. And she walked up to him and she said, Dr. Hari Menon, do you remember me? I was your patient in AIIMS in Delhi. And I was just watching the bonding that happened between the two of them. And that is very special. It's only because, you know, we have this kind of treatment for a disease which at one time was thought to be, you know, a fatal disease. And that was a very special moment, actually. I just felt like sharing it.
Okay, moving on. What is the impact of the disease on the psychological and hormonal changes the young patient undergoes while on treatment? Dr. Ross? Psychological and hormonal changes.
I don't think I can really answer that question. I think to know what's happening in the mind, you really have to ask people who are taking these drugs. I can only guess what's happening inside your mind. And, you know, obviously this is something that I think about, and it's something that I'm interested in. I don't know whether people having the disease, whether it's a constant worry, whether the tablets make them feel safe, whether people worry about being different from their friends. I don't know. I don't think I can answer this question. In terms of hormonal changes, there is some concern. Obviously, diabetes is an issue because of increased blood sugar levels on nilotinib and decreased blood sugar levels on imatinib and dasatinib. But otherwise, there isn't a clear hormonal problem that I'm aware of. There was some concern maybe about thyroid function on some of the TKIs. But I don't think that we commonly see major hormonal problems.
Dr. Chang?
I have nothing to add. Perhaps you're the expert in this.
Okay, Pramod.
What's going in the mind? Doctor said, ask a patient. Like Vijay said, I might have been young when I was diagnosed at 28 or so. And it was an honor to be diagnosed and declared a CML patient by the doctor in a very lighter way. That, the moment it was disclosed, the way it was disclosed with a handshake by the doctor and a congrats that you have a good cancer, that took away a big load from me. And the first question I asked my doctor, when the doctor said that congrats, you have a good cancer, I asked, what do you mean by good cancer? He said, just like diabetes, a person with diabetes taking insulin, you just have to take a tablet every day. That's it. So a big life-threatening incident, cancer, is disclosed to a patient by saying that it's a good thing that you have and there's a tablet for it. So, but at the same time, if someone's heard this in a very different scenario, the psychological change would be much different. So how the news is broken to you? Like Vijay was saying that last week when we had this patient meet, I met a patient's husband who's giving medicine to this lady for the past 6 years and having not told her. Just imagine, one fine day, she reaches the meeting. Now this was the first time that she came in for a meeting. And then she comes to know that all the people here are cancer survivors, and I also am a cancer survivor. So how that is going to take an impact on that lady? So somewhere mind plays a big role, but how it's explained to that person, how that patient is exposed to this thing plays a bigger role.
Let me share a short story. There was a time when I had difficulty having my kid complied with the dosage. So I thought psychologically how I could deal with him. And I told him, you know, you are rare because only 0.05% of the CML population are adults. You are rare. God gave you this rarity. And you know what he said? He said, but I don't want to be rare, Dad. I want to be like the other kids playing outside. So how do you deal with it? So really, it's a world in itself. And what hit me, Dr. Ross, when you said rebellion, you know that there is a website for rebellious kids. It's called the F word. You know the F word? fcancer.org. Check it out. It's for kids with cancer, but they're on a different world. It's these rebellious kids that group together, but on a positive note. It's their mentality. It's the F word, but they're doing their best to cope with it. So moving on. Are physicians encouraging more young patients to switch sooner to second-generation TKIs, keeping their age and longer survival rates in mind? Dr. Harry.
Well, personally, I follow the same guidelines as I would for any patient when discussing them as to what drugs they need to use. Certainly, when in a young patient, I'm concerned because they are on a long-term, they need to be on long-term medications. And when we are treating, I again use the same guideline. If you see that if they have a high SOCAL index or something at baseline, I would certainly consider using a second generation and first line setting. But otherwise, I use the same guidelines, looking at what the responses would be to determine whether the patient has to go in for a second line or not at any point of time.
Dr. Harry.
In terms of switching, I have the same answer as Dr. Hari. In the Japanese situation, we can use second-generation TKIs in the first-line setting. And in that setting, because of the difference in the side effect profiles and younger generations don't have other comorbidities that would make them more prone to some side effects like the vascular diseases, it's easier to use the second-generation TKIs and in the first-line setting for the younger generations. The other aspect I would take into consideration would be because they have a longer survival rate, also it means that we may have a potential of getting them into a deeper molecular response using the second-generation TKIs with a potential for discontinuation of the drugs, although this hasn't been actually proven yet. But with the results of the other trials coming in the next few years, this might be something to put into consideration.
Thank you, Dr. Harry. That's why we put their longer survival rates in mind. Okay. Having seen that there is resistance and mutation Do you think younger patients should be given the option of BMT upon diagnosis? Dr. Ross.
I don't quite understand the question because at diagnosis you don't know whether there's going to be resistance or mutation. You only find those things later after the person has been on treatment for some time.
Okay, so let's take that scenario. It's
So-
been long.
Because say if someone's been on treatment for a period of time and develops resistance, then certainly I would be tissue typing them to see whether a transplant is an option. Because depending on whether they have a matched brother or sister or whether they need an unrelated donor, this will influence the risk associated with the transplant. And I would also look at the nature of resistance. If the resistance is transformation to accelerated phase or blast crisis, then I would certainly be looking at moving toward a transplant in that patient. If it's the emergence of T315I, then I would certainly be seriously considering a transplant, particularly given the limited availability of ponatinib and the concerns about vascular events with long-term use of that drug.
So not much difference in adults and adolescents with the way you're...
Well, in a younger person, the risks associated with a transplant are lower, which makes it easier to recommend a transplant for a young patient. The decision-making process is exactly the same, but when you weigh up the risks on one side and the risks on the other side, it's easier for a young person to have a transplant.
Dr. Cham?
I presume that you are referring to patients like if they're under 20 years or under 25 years, or, you know, I think the option of a transplant at diagnosis should always be given to them at the time of diagnosis, meaning that, you know, we should explain these are the possibilities, transplant, what are the risks, TKIs. As a physician, I would veer them towards at least a trial of TKI first. That would be the first option, and then seeing what their response is going to be like, you know, and then even if they wanted a transplant, you know, at upfront, I would still think that it is better to control the disease first with some TKI. I mean, there will be one or two patients who would say, you know, look, I don't want any long-term treatment, I just want a transplant. Now, there would be an occasional patient that is, you know, who is very fixed in their minds, they don't want any chemicals or any long-term sort of thing in their body. So, but yeah, I would say that, you know, I would explain to them that there is this option available to you, you know, but I would suggest that, you know, you go on TKI and then, you know, we monitor and see whether you meet this time point. Because you may have a patient who is a very rapid responder to doing very well on the TKI who has a very long chance of survival.
Of course, that's assuming that's between the age group that are already mature. Yeah. Okay, so we're close to ending except for the take-home messages from our panelists and our experts. Dr. Hari, would you like to start?
We don't need to do things differently for any age group per se. It's well defined as to who are the responders, who are not the responders, and take them one at a time and see what the responders. Then take an action accordingly or advise them accordingly as to what to expect in the future. Certainly, when it comes to young patients, I do inquire about the possibilities of doing an HLA typing for these patients and keep it in readiness so that that is a possibility that I'm always looking at in the future. But and telling them at the same time that this is just a backup plan, and we need to look at how your responses are. And certainly, I would push for a transplant if the responses are not to my liking, because we are again dealing with young patients, and we probably have to take some more hard decisions as far as they are concerned. So otherwise, most of the things are pretty much clear as to what to do in CML, depending upon responses at different time frames.
Okay, since your taxi is waiting, Dr. Cham, the organizer told me for you to give your take-home message first. Sorry, Dr. Eri.
I think many people now are living with CML. They are going to GPs, they are going to the community physicians, and I think there's a lot of work to be done to get the message out there, because many community physicians do not understand what are the side effects of Gleevec, you know, what are what are the problems that it may cause. I think there's a lot of work to be done, you know, on informing medical physicians outside there. The other thing is that I feel that, you know, intolerance is something that, you know, we really should be looking at, because a lot of us physicians do not take intolerance very seriously. We just think, you know, it's going to be part and parcel of your life. You have to, unfortunately, just too bad. You know, you will have a bit of nausea. Every time you eat anything, you have to rush to the toilet, you know, because of the diarrhea, you know, it is part and parcel of the life. But intolerance leads to loss of cytogenetic response, poor outcome, you know. I think if we can try to address that issue and physicians are more aware, then perhaps patients can be switched earlier or, you know, have better outcomes.
Thank you, Dr. Chang. Back to you, Dr. Eri. Sorry.
On top of everything that's been said, I personally emphasize two things in the younger population. One is about family planning, your situation in terms of your own family, your parents, and the supporters that you have in terms of treatment, and how to coordinate those into the setting that is very most comfortable for you to continue treatment. The other issue is financial issues, especially for the younger population. If you just started working, sometimes the cost of treatment is a huge burden for you in choosing your job or just continuing your job. And that is another thing that I emphasize, that you have a good communication with whoever you're with. And also, above all, have a good communication with your treating physician. Find out what is the best solution for your situation.
Okay, Pramod.
I'll just add one thing here. With the young adults, when you're diagnosed and when you are broken the story, if there's a bit of hand-holding, that helps us in a long journey. Like, when it's being diagnosed, if this patient can be put in touch with a patient who's survived for a longer period and who's moving with a positive attitude. Like, I know a person who's he's in the other part of the country. I've not met him. But for the past 6 months, he's in touch with me. And with every development that he had a small headache, he used to check out with me. What should I be doing? And today, after 6 months, after his reports, next round of reports that come in, very positively, he sent a message, Pramod, thanks for holding my hand all through this period. And today, my reports are very positive. He had a lot of things, doubts in his mind, and like I said, he was again a Google searcher. With whatever reports that he used to get, he used to come back with me and ask me. I've not met him till date, but that hand-holding, that positiveness has passed on, and today he was very positive. Like 15 days back, he SMSed me saying that my reports are all good. So I said that hand-holding is something that needs to be done at the initial stage, so that takes that patient to a longer lifestyle.
I totally agree that we have a young patient here. She went to the third rising sun. She's crying. Now she's very happy that she met a lot of patients. She's doing well. She's inside the room. Dr. Ross, would you like to close with a take-home message?
It's very hard. I think if I had a single take-home message, it's that it's important to have a discussion about where your treatment is going to go in the long term and what's important to you in your life. People have to understand that if they're going to be on this drug for many, many years, it's going to be an important part of their life, and they should have a good quality of life as well as having good control of their leukemia.
Okay, so we would like to thank our panelists for giving some enlightening thoughts and also the scientific data we could take home.